Hello, everyone. I'm Karthik Murugiah. I'm an interventional cardiologist and an assistant professor of medicine at Yale University. I'm also an executive associate editor at JACC. The 2025 Acute Coronary Syndrome guidelines were published earlier this year, and they included several notable changes and updates to prior recommendations. In this video, we will focus on the guideline updates specifically for the management of acute MI complicated by cardiogenic shock. This video accompanies an editorial I had the opportunity to write along with some of my esteemed colleagues for JACC as a part of our ACS 2025 guideline update issue, which takes a deeper dive into these guideline changes. And I encourage you all to read it if you have a chance. So, cardiogenic shock complicates 10% of acute myocardial infarctions and is associated with a high mortality of 50%. Concerningly, this poor prognosis of acute MI complicated by cardiogenic shock, which we can abbreviate as AMICS, has not improved in recent decades. Temporary mechanical support devices are frequently used in AMICS to support the failing heart. A recent study in JACC showed that 2/3 of patients with AMICS treated in US critical care units received more than one temporary mechanical support device. 22% of them received microaxial flow pumps, 10% received VA-ECMO, and 44% received intra-aortic balloon pumps, or IABPs. A report from the NCDR registry of AMICS patients who underwent PCI, but this is slightly older data from 2015 to 2017, showed that 43% of patients received temporary MCS with an increasing trend in the use of microaxial flow pumps. However, 70% received only IABP. This indicates that IABP is still the dominant temporary MCS modality in US practice. The evidence base for the use of temporary MCS in AMICS, however, is not as robust as other phases of AMI care. And this has severely limited the evidence that guidelines have had at their disposal to make recommendations. Enrolling patients in RCTs in AMICS has always been challenging. These patients are really sick and need timely emergent care with primary PCI, etc., which makes it challenging to enroll them. Often, there may be other ethical barriers in recruiting. However, since the last 2013 STEMI guidelines and the 2014 NSTEMI guidelines, several trials have been completed in this space, which inform these guideline changes. The first change is that routine IABP use in AMICS gets a downgrade from Class 2A, or a maybe reasonable recommendation in the 2013 STEMI guidelines, to a Class 3, or no benefit recommendation. This change follows the lack of mortality benefit at 30 days with IABP in the IABP Shock 2 trial, which was a trial of 600 patients. This was published in 2012. The mortality in the IABP arm was 39.7% compared with 41.3% in the control arm. So no difference in those two arms. The 6-year follow-up of this trial continued to show no difference in mortality. This trial is over a decade old, and unlike the US, routine IABP in AMICS has carried a Class 3 recommendation in Europe since the 2014 ESC REVASC guidelines. And use of IABP in Europe for AMICS has been much lower than what we observe in the US. Now, with these new guideline changes in the 2025 ACS guideline updates, similar decreases should be expected in the US, and it'll be important to monitor that via registries such as the NCDR. The second change in a similar fashion is the Class 3 or no benefit recommendation for the routine use of VA-ECMO in AMICS. Prior guidelines did not carry explicit recommendations for VA-ECMO due to a lack of trials. This new recommendation comes on the heels of 2 trials of VA-ECMO in AMICS. The smaller 2023 ECMO-CS RCT, which enrolled 117 patients, of which 2/3 had AMICS. There was no mortality difference observed at 30 days and 1 year between an immediate VA-ECMO strategy versus a no immediate VA-ECMO arm. Although driven by clinical indications, 40% of this group ultimately received ECMO. There was no difference, though, noted in safety events, but this trial was limited by sample size. The larger 2023 ECLS shock trial that enrolled 420 patients, and it also found no mortality difference with an early VA-ECMO strategy at 30 days with a mortality of 47.8% versus a control arm with a mortality of 49%. And there was no mortality difference again at 1 year as well. However, they did note an increase in ischemic limb and bleeding complications with the ECMO arm. This is where the Class 3 recommendation comes from for VA-ECMO in the new guideline update. However, it is important to remember that this new Class 3 recommendation for VA-ECMO only suggests against its routine use. And for patients with deteriorating shock, as we all encounter in practice, VA-ECMO remains a key salvage temporary MCS modality. The third guideline update, and probably the one that has garnered the most attention, is the upgrade and recommendation for microaxial flow pumps. The new guideline statement specifically says, in selected patients with STEMI and severe or refractory cardiogenic shock, insertion of a microaxial intravascular flow pump is reasonable to reduce death. This is a change from the 2B recommendation in the 2013 STEMI guideline for alternative LV assist devices, which would include a microaxial flow pump. As I just mentioned earlier, in the US, microaxial flow pumps, such as the Impella CP, have been increasingly used in AMICS. However, until the recent Danger Shock trial, there was scant evidence supporting their use. The Danger Shock trial is the first large trial studying the use of these devices in STEMI CS. Danger Shock enrolled 360 patients and showed that routine microaxial flow pump use, specifically the Impella CP, in STEMI patients with cardiogenic shock, significantly reduced 180-day mortality. The mortality in the microaxial flow pump arm was 45.8%, and in the control arm, it was 58.5%, so a whole 13% higher. This, however, was associated with an increase in adverse events, such as bleeding, 21.8% in the microaxial flow pump arm versus 11.9% in control, limb ischemia, 5.6% versus 1.1%, and renal replacement therapy, 41.9% versus 26.7% in the control arm. Some of the complications, such as renal replacement, is a function of increased survival, but it's important to note that this device, although it reduced mortality, does come with an increased risk of serious adverse events. This is where the guidelines try to incorporate the nuance in the evidence put forth by the Danger Shock trial in the way that they word the recommendation statement. First of all, this recommendation only applies to STEMI patients, as the guideline statement clearly states. Then, they emphasize the word selected patients with an asterisk to bring to attention the narrow selection criteria of Danger Shock. Danger Shock notably excluded patients with right ventricular failure, those without suitable peripheral access for these devices, and importantly, they excluded patients who had a GCS or Glasgow Coma Scale of less than 8. This is a much stricter criteria than the other temporary MCS trials, which excluded only severely comatose patients or those with long resuscitation times. Thus, it is very important to put the patient in front of you in context of the trial population. A recent study in JACC, in fact, showed that of all patients with STEMI CS, 2/3 would not meet Danger Shock enrollment criteria. Whether a microaxial flow pump would benefit patients who do not meet these criteria remains unknown. This does not mean that they will not benefit. It is just that we do not know, and thus use should remain judicious. Similarly, on the counter, whether IABP or VA-ECMO would have benefit if applied to the narrow selection criteria of Danger Shock also remains unknown. Second, the guideline statement also emphasizes the word mortality. And this is to bring to attention that adverse events are increased in the device arm, such as bleeding, limb ischemia, and renal replacement therapy, which have consequences for the patient. This high adverse event rate with microaxial flow pump, despite the trial being conducted at selected centers, presumably with good temporary MCS experience has important implications for the safe use of this device. It is imperative that physicians and critical care teams must have or develop expertise in microaxial flow pump management to mitigate these risks and deliver the most benefit possible to our patients. There are also other aspects regarding the use of this device that we do not understand well, and we need more data on, such as what is the optimal timing of the use of a microaxial flow pump? The danger shock trial allowed these devices to be used prior, during, or for 12 hours after PCI. As a closing statement on this, danger shock is the first temporary MCS trial to show a mortality benefit in any AMICS population, which was much needed for this really sick population and deserves every bit of applause. This trial is bound to influence practice, and even more so now with the 2025 guideline changes. However, just as we push for more trials and continue to innovate in this space, we must continue to leverage real-world data to follow the outcomes of this extremely sick population so that we are using the tools we have at our disposal appropriately. Hope this was useful, and thank you all for listening.